Welcome, everyone, and thank you for joining us today. My name is Jia Yang, and I'm assistant professor at the Institute for Global Health and Development at Peking University. Today's webinar is part of our colloquium series this year on healthcare workforce issues in Asia, jointly hosted by IGHD at Peking University and the Asia Health Policy Program at Stanford. We are delighted to have with us today two outstanding young scholars whose work focuses on behavioral responses in physician decision-making. Physicians, as economic agents, respond to a variety of behavioral and institutional incentives, and understanding these responses has important implications for healthcare efficiency and welfare. And the two papers we will hear today speak closely to these issues and complement each other very nicely. For the sake of time, I'll keep the following introductions brief, and please feel free to refer to our website for the speakers' full biographies. Our first speaker, Dr. Wei Yan, is an assistant professor at the School of Finance at Renmin University of China. She received her PhD in economics from the National University of Singapore, and her research examines the interactions among healthcare providers, patients, and insurers, with a particular focus on how incentive structure and information asymmetries among these actors shape decision-making. And our second speaker is Dr. Jia Xiang, an assistant professor of business economics and public policy at the Kelley School of Business, Indiana University. And she received her PhD in economics from Penn State, and her research interests include industrial organization, health economics, and applied microeconomics. For our audience, if you have any questions during the presentations, please feel free to post them in the chat, and I'll collect them and bring them up during our Q&A session after our two speakers finish their presentation. So without further ado, let me now turn it over to our first speaker, Dr. Wei Yan, who will present her work on physicians' reference dependence. So, Wei, please.
Great. Thank you, Jianan, for your kind introduction. Let me share the screen. Thank you for the invitation, and I'm very happy to present this paper today. Today, we will talk about our paper, Optimal Payment Levels for Reference-Dependent Physicians, and this is a joint work with Zhicao, Junjianyi, Chuan Zhang, and Hangzhou. Let me start with the motivation. In many markets, supply of goods and services can be distorted due to market friction such as information asymmetry or market power. And to address these issues, policymakers often adopt the prospectively fixed payment policies. Under such policies, the payment for a bundle of services is fixed in advance, regardless of the actual cost incurred by the provider. The key idea is that the prospectively fixed payments remove marginal incentives for overall annual supply, and these policies are widely used in many sectors such as healthcare, education, some riding-sharing platforms, and agriculture. However, the introduction of the fixed payment may lead to behavioral distortions. A large literature in behavioral economics shows that individuals have reference-dependent preferences. And people with such preferences, people tend to evaluate outcomes relative to a reference point, which is often based on their past experiences. For example, in the context of healthcare, physicians may compare the newly introduced fixed payment with their familiar pre-existing revenue, and this comparison creates perceived gains or losses. And because of loss aversion, they may respond more strongly to perceived losses than to gains. As a result, the level of the fixed payment can affect policy outcomes, even though it does not affect marginal incentives of the physicians. And in practice, this payment level is typically determined on an accounting or clinical basis. For example, it is determined based on historical averages or by a group of clinical experts. The microeconomic foundations for determining the payment level are often overlooked by both researchers and policymakers. And in this study, we investigate the optimal payment level under prospectively fixed payment policies, considering individuals' reference dependent preferences. We focus on prospective payment schemes or PPS in healthcare markets. These payment schemes are widely adopted around the world to curb the overprovision of healthcare. And we have three main research goals. First, we provide empirical evidence that physicians have reference-dependent preferences. And second, we develop and estimate a model of the medical decision-making. Our model has two features. First, medical decisions are made jointly by patients and physicians. And second, physicians have reference-dependent preferences. Finally, based on the model estimates, we determine the optimal payment level under prospective payment schemes. Next, let me introduce the institutional background. The healthcare supply in China. Public hospitals dominate healthcare provision in China. They account for nearly 90% of both outpatient and inpatient services. Public hospitals also have strong financial incentives. Before 1980s, they received substantial government subsidies, which accounted for about 60% of hospital revenue. But today, this share is much smaller. As a result, hospitals have to rely heavily on the payments from public insurance and out-of-pocket expense from patients to financially survive. Another important feature is that physicians and hospitals are closely aligned. Physicians typically receive relatively low salary, a low base salary, but a large share of their income comes from the performance-based bonuses. And this compensation structure creates strong incentives for physicians to consider the hospital's financial interests when making medical decisions. Therefore, throughout our analysis, we treat the hospital and the physician as a single agent. There are two main public health insurance programs in China. The first one mainly covers people without formal employment. And second is the Urban Employee Basic Medical Insurance, or UEBMI, which is the focus of our study. UEBMI is mandatory for urban employees and retirees, and it is managed by local governments. The reform we study was implemented within this UEBMI. Our analysis focuses on rehabilitation care because this is a payment reform targeted on rehabilitation care. The rehabilitation aims to improve functioning and reduce disability after the patients suffer from major illnesses or injuries. The clinical literature has identified a wide range of conditions that require rehabilitation. And compared with acute treatment, rehabilitation has several distinctive features. First, rehabilitation typically lasts for several weeks and requires intensive interactions between physicians and patients during the treatment process. And many medical studies show that closer patient and physician collaboration during this process can significantly improve treatment outcomes. Second, patients are actively involved in rehabilitation. They often take responsibility for daily training and medication management themselves under the physician's guidance. And third, the price elasticity of demand for rehabilitation care is found to be significantly higher than the overall price elasticity of healthcare demand. And these features make rehabilitation an ideal setting to study medical decision-making process, which I will discuss later. With population aging and the rising prevalence of chronic diseases, the clinical need for rehabilitation is substantial in China and also all over the world. However, an important challenge for global promotion of rehabilitation is that patients typically lack awareness of rehabilitation and lack knowledge about it and tend to undervalue its benefits. And in China, rehabilitation services are mainly concentrated in large cities and high-tier hospitals, and there is no well-established referral system. Our empirical analysis is based on a reform that took place in Changsha, a large provincial capital city in China. In 2015, the UEBMI implemented a reform that changed both the hospital payment schemes and the patient reimbursement structures for rehabilitation care. And this reform was piloted in 7 hospitals. The reform covered five categories of diagnosis, including stroke, spinal cord injury, traumatic brain injury, recovery from brain tumor surgery, and recovery from joint replacement. In total, the reform involved 110 diagnoses. Let me explain the reform in more detail. Before the reform, hospitals were paid under a fee-for-service scheme. This means their revenue was simply equal to the total medical expense. And after the reform, hospitals receive a fixed payment PG based on the admissions diagnostic category. G here denotes the diagnostic category. We have 5 categories as mentioned in the previous slide. This means that the fixed payment P differs across the 5 diagnostic categories, but it is the same for different diagnoses within each category. At the same time, the patient reimbursement structure also changed. Before the reform, patients' out-of-pocket expense is determined by the medical expense, claimable expense, deductible and reimbursement rate. The out-of-pocket expense typically increases with the medical expense. After the reform, patients pay a fixed share of the predetermined fixed payment PG, and for employees, they pay 15%, and for retirees, they pay 10%. This reform provides an ideal setting for a study for several reasons. First, the reform eliminates marginal incentives for both physicians and patients. Physicians no longer gain additional revenue from providing more services, which tends to reduce their healthcare supply. At the same time, patients no longer face increasing out-of-pocket expense, which tends to increase their demand. This creates an interesting situation in which patient and physicians' incentives move in opposite directions. And second, the reform generates varying changes in physician revenue across diagnoses and hospitals. Let's see this example. Here, this table lists the 20 most common diagnoses in stroke. Before the reform, we can see that the medical expense varies greatly across diagnoses and across hospitals, from about 6,000 to more than 30,000. And the average expense in tier 3 hospitals is typically higher than that in tier 2 hospitals. But however, after the reform, the hospital received a uniform fixed payment of 18,000. Therefore, for some diagnoses, the newly fixed payment is lower than the previous physician revenue, while for others it is higher. This variation allows us to investigate whether physicians respond differently to the potential perceived gains or losses. Third, most patients in our setting undergo rehabilitation only once, and so they are unlikely to know the pre-reform out-of-pocket expense. This may explain why we do not find evidence of patient reference dependence in our empirical analysis, which I will show you later. But this much simplifies our analysis. Finally, the rehabilitation system in China leaves little scope for selection by either patients or physicians. Patients, as we discussed before, they typically lack knowledge about rehabilitation services, and decisions about whether and where to receive rehabilitation are usually made during the acute treatment stage. And in practice, these decisions are largely guided by physicians in acute care departments instead of the physicians in the rehabilitation departments. And because there is no formal referral system, patients who require rehabilitation are usually transferred directly to the rehabilitation department within the same hospital. And we also examine this potential selection in our later analysis. Next, let me describe the data. We use two administrative datasets from the UEBMI in Changsha, covering the years from 2013 to 2015. The first dataset is insurance claims data, which provides detailed diagnostic and financial records for each admission. The second dataset is the enrollment data, which contains the patient characteristics such as age, gender, or monthly salary or pension. Our treatment group includes about 9,000 admissions in 7 hospitals involved in the reform, and the control group consists of about 22,000 admissions in the other 22 hospitals in Changsha. Since the hospitals in the treatment group are all Tier 2 or Tier 3 hospitals, and each has at least 5 rehabilitation admissions per year, we select control hospitals with similar characteristics, namely Tier 2 or Tier 3 hospitals of comparable size. In this study, we use the variable medical expense in the data as a measure of the amount of healthcare provided to the admission. This medical expense is defined as the total bill of all services provided during the admission. Both before and after the reform, hospitals calculate and report the medical expense for each admission to the Healthcare Security Administration for administrative purpose. We then construct a key variable called the change in average hospital revenue. This is defined as the difference between the new fixed payment and the pre-reform average medical expense for a given diagnosis in a given hospital. If this value is negative, the reform reduces physician revenue. If it is positive, it means that the reform increased the physician's average revenue. Here, the two figures show the evolution of medical expense for the treatment and control groups, for admissions in the treatment and control groups over time. In the left figure, we compare admissions with negative delta P to those in the control group. And in the right figure, we compare admissions with positive delta P with admissions in the control group. Before the reform, we can see that medical expense are stable for both the treatment and control groups. After the reform, however, the medical expense declined for admissions where physicians receive lower average revenue than before, and increase for admissions where physicians receive higher revenue. To further investigate this, we further classify admissions in the treatment group into 10 classes based on their value of delta P from low to high. We then estimate the reform's impact on the amount of care for admissions across the 10 classes using the DID specification. This figure shows that the reform's impact varies systematically depending on whether the physicians receive a higher or lower average revenue. When the reform reduces physicians' revenue, the amount of care decreases due to the reform. And in contrast, when physician receives higher revenue, the care amount tends to increase. Importantly, we do not observe similar heterogeneity with respect to the changes in patient out-of-pocket expense. A possible explanation is that, as we mentioned earlier, the most patients undergo rehabilitation only once, so they may lack prior experience to form a reference point. Before introducing our model to explain these heterogeneous impacts, we examine several alternative interpretations. These include hospital selection, mean reversion in medical expense, anchoring effects and heterogeneous policy impacts driven by differences across hospitals, patients, diagnosis or admissions. If you are interested in any of these explanations, I would be happy to discuss them further during the Q&A. Overall, the results do not support these alternative interpretations. So we develop a model to understand the reduced form findings. Our model has two key features. First, the medical decision is made collectively by the physician and patient. Because the reform eliminates both the patient's marginal out-of-pocket expense and the physician's marginal revenue, if the decision were made solely by patients, the amount of care would decrease for all admissions. And if it was made solely by physicians, the amount of care would decrease for all admissions. This contrasts with our finding of the heterogeneous impacts. So we allow the decision to made jointly by these two. Second, physicians have reference-dependent preferences. This helps explain why the reform's impact differs exactly by whether the physician receives a higher or lower average revenue across the reform. Let's see the patient utility first. The patient receives the amount of healthcare, which we denote by E. The patient utility depends on two components. The first is the health benefit from the treatment, HE. We assume that the health benefit from the first unit of care is sufficiently large so that both the patient and the physician agree to start the rehabilitation. And the marginal health benefit decreases with the E, and the marginal health benefit can be negative when E is sufficiently large. The second component is the out-of-pocket expense paid by the patient, which is determined by the reimbursement structure of the UABMI. Alpha measures the patient price sensitivity, which converts the patient's health benefit into a monetized value. Next, consider the physician. The physician earns profit, which equal to her revenue minus cost. For tractability, we assume a linear cost function here. And the physician revenue is determined by the payment schemes of the UEBMI. The physician has reference-dependent preferences. Pi r here is her reference point for profit, where r is the critical amount of care that enables the physician to reach her reference point. The physician's utility consists of two components. The first one is the intrinsic utility from profit, and the second is the gain-loss utility relative to the reference point. The parameter eta measures the importance of gain-loss utility relative to the intrinsic utility. When the profit is higher than the reference point, the physician experiences a gain utility, and when it falls below the reference point, the physician experiences a loss utility. The parameter lambda is greater than 1, which captures the degree of loss aversion. We model medical decisions as a collective choice between the patient and physician. The optimal amount of care maximizes the weighted sum of patient utility and physician utility, and parameter theta represents the patient bargaining weight, and 1 minus theta represents the physician's bargaining weight. Under this framework, the optimal amount of care depends on three factors. First, the financial incentives of both the patient and the physicians. And second, the bargaining weight between the two parties. And third, the physician's reference point. Before the reform, the patient out-of-pocket expense increases with the medical expense. And delta zero here is the patient pre-reform cost-sharing rate. The physician profit is equal to 1 minus C times the medical expense, which increases with the amount of care. Following the literature on backward-looking reference points and associative memory, we assume that physicians form their reference point based on past experiences from treating similar cases. Under this assumption, in a steady state, the physician's reference point for profit equals the profit she actually earned. Before the reform, the physicians had adapted to this steady state, so the optimal amount of care is equal to the critical amount of care required to meet the physician's reference point. But next, let's see the optimal amount of care after the reform. By assumption one, after the reform, the the out-of-pocket expense and the physician's profit all changed after the reform. And now the physician's profit decreases with the amount of care. By assumption one, after the reform, the physician continues to hold a reference point equal to the profit she earned before the reform. We can then derive the critical amount of care after the reform, which depends on the gap between the fixed payment and the pre-reform medical expense. The optimal amount of care after the reform depends on the value of this critical amount of care R1. If R1 is sufficiently high, meaning that the fixed payment is much higher than the physician's previous revenue, the physician tends to perceive the reform as a gain, and the optimal amount of care lies in the gain domain. Conversely, if R1 is low, which implies the fixed payment is below the physician's previous revenue, it threatens to push the physician's profit below her reference point. And due to loss aversion, the physician may respond strongly by reducing care, and the optimal amount of care now lies in the loss domain. And when the fixed payment lies within an intermediate range, the optimal amount of care can be exactly R1, which allows the physician to just meet the reference point. So since the optimal amount of care after reform depends on the value of R1, the fixed payment now can influence the optimal amount of care through R1. The impact of the reform depends not only on the reference point, but also on the marginal incentives on the marginal changes in physician and patient utilities, as well as their respective bargaining weights. First, for the patients, because the reform eliminated the patient's marginal out-of-pocket expense, this would increase the marginal collective utility by this amount of value from the patient side, which tends to increase the optimal amount of care. And second, the reform eliminates the marginal physician revenue, which would reduce the marginal collective revenue from the physician side. And this reduction in marginal collective utility is particularly larger when the physician perceives losses than when she perceives gains due to loss aversion. And the overall effect of the reform depends on the relative strength of these forces. There are three possible scenarios. First, if the decrease in marginal collective utility always dominates the increase, the reform reduces the amount of care for all admissions. And second, if the increase in marginal collective utility always dominates, the reform increases the amount of care for all admissions. Third, if the increase dominates when physicians perceive gains, but decrease in marginal collective utility dominates when physicians perceive losses, the reform generates heterogeneous impacts depending on whether this gap is positive or negative. And the third scenario is consistent with our reduced form finding. Before estimating the model, we also examine whether the reform's impact could be rationalized by an alternative collective model in which physicians do not exhibit reference-dependent preferences. We refer to this model as neoclassical collective model. We find that in this alternative model, heterogeneous impacts could arise only if the pre-reform cost-sharing rate or bargaining weights differ systematically between admissions with the therapy less than zero or those with therapy greater than zero. Since we can observe this pre-reform cost-sharing rate, we directly test whether it has such systematical difference in our data, and we do not find such systematical differences. Therefore, the remaining possibility is the systematical heterogeneity in theta. In our structural estimation, we estimate both our behavioral collective model and a neoclassical collective model that allows for rich heterogeneity in theta, and we evaluate which model better fits the data. Under a bunch of parameterization assumption, we estimate the model using MLE. The policy reform combined with the structural model provides the identification source. Due to the time constraints, let me skip the identification detail and let's see the results. The table reports the parameter estimates for both the behavioral model and the neoclassical one. The marginal cost is about 0.7. Patients exhibit substantial price sensitivity. Patients have higher bargaining weight than the physician here, which is consistent with the context of rehabilitation care. The estimate of lambda, the degree of loss aversion, is 3.5, which is comparable to the estimates in the behavioral economics literature. Column 2 reports the estimates for the neoclassical collective model. The value of the log likelihood function is lower than that for the behavioral collective model, even though the second one has much more parameter. We further evaluate how well the model fits the data by comparing the observed policy impacts with the predicted impacts from the two models. The behavioral model matches the observed data more closely than the neoclassical one, even though the neoclassical one has more parameters. This result suggests that incorporating physicians' reference-dependent preference substantially improve the model's ability to explain the data. Finally, we solve the optimal payment level under prospective payment schemes. We consider the problem of a social planner who considers the trade-off between patient health benefits and the total healthcare expense, in which the latter includes both the payment from the UEBMI and the out-of-pocket expense from patients. The social planner chooses the optimal payment P star to maximize its utility, subjected to incentive compatibility for both the patient and physician. And using model estimates, we simulate the optimal amount of care and the social value of the social welfare under different payment levels. And we can find the optimal payment level that maximizes the social welfare. This figure shows the optimal payment level for stroke rehabilitation. The optimal payment level is 16.6 thousand, which is lower than the current observed payment. And by adjusting this payment level from the observed to the optimal, the patient, it can improve the patient and social welfare and decrease the payment from UEBMI and patient's out-of-pocket expense. These are the main findings of the paper. We contribute to both the health economics and the behavioral economics literature from several aspects. For future research, we think it would be very interesting to consider the reference-dependent preferences of both the physicians and patients, or to study how the reference points evolve dynamically over time. Yeah, that's all for my presentation. Thank you.
Thanks a lot, Wei, for the wonderful presentation. Actually, I do think there's probably a quick question I can ask here. Probably our audience are interested as well. So you mentioned a bunch of alternative hypotheses. I just want to have you briefly talk about how you rule out the anchoring effect. Probably that's the question I've been thinking about the talk.
So anchoring effect means that if the physician interprets fixed payment as an implicit suggestion by the government and regard it as a psychological anchor in decision making, then they would adjust the medical expense to meet this psychological anchor. Then if this is the explanation, we would see that the medical expense after the reform would tend to, we will see a bunching around the fixed payment after the reform in medical expense compared to that before the reform. So we simply plot the distribution of medical expense both before and after the reform. And this is the distribution for stroke rehabilitation, for which the fixed payment is 18,000, and we do not find that the medical expense would bunch around this fixed payment. So that's how we rule out this interpretation.
Thanks for the explanation. And just to remind our audience, if you have any questions for Wei and Jia as well during the next presentation, please enter them in the Q&A function, and we will bring them up after Jia finishes her presentation. So thank you again very much, Wei. And next, let's welcome our second speaker, Dr. Jia Xiang, and who will present her co-authored work on physicians' fear and risk perceptions in response to malpractice lawsuits.
All right, thank you very much for having me here. I'm very thrilled to talk about the work titled as Fear and Risk Perception, Understanding Physicians' Dynamic Responses to Malpractice Lawsuit. I had a pleasant journey with two lovely co-authors, Han Min from University of Pennsylvania and Min from Chinese University of Hong Kong, Shenzhen. Let me start by talking about provider decision-making. So physicians' decisions are important, both in terms of in determining the quality and the cost of healthcare. And the providers routinely make decisions under uncertainty. They are considering financial incentives, treatment risks, and patient outcomes. But there's a less explored question regarding how do providers respond to those infrequent yet emotionally charged events. And that's going to be the focus of our project. So in this paper, we're going to talk about this problem in the context of malpractice lawsuits. And specifically, we're going to ask, how do providers adjust their treatment decisions after malpractice lawsuits filed either against themselves or their colleagues? There are at least two possible scenarios where you can imagine how providers might respond. Scenario one is there might be an increased perception of the risk of malpractice litigation, and physicians might engage more in practicing defensive medicine. So what is defensive medicine? It refers to the care that is chosen to reduce those legal risks rather than to benefit the patient. And usually it comes with two forms. You could think of some assurance behavior. Usually those refers to unnecessary care, like unnecessary lab test, unnecessary medicine. And the second form is avoidance behavior, where physicians or hospitals might reduce the likelihood of high-risk procedures, or at the extensive margin, they might also refuse to admit high-risk patients. So both forms can be considered as defensive medicine as long as the primary goal is to reduce the occurrence of malpractice lawsuit instead of to benefit from the patient health. Now, there might be another scenario. You might imagine that after those malpractice lawsuits, the hospitals or physicians might change their behavior to correct the previous medical errors. And the empirical evidence that we found in this paper points to the defensive medicine story. So our evidence shows that we are in scenario one, where physicians or hospitals respond by practicing more defensively. And then another question that we explored is, to what extent do providers respond to lawsuits due to non-pecuniary cost? So if you think about why do providers would respond to malpractice lawsuit, that's because those lawsuits would bring them substantial cost, right? On one extreme, you can think of all the pecuniary cost, the financial cost. For example, they might face a higher malpractice insurance premium. They might lose business or patient to the competitors, or the individual physicians might be fired or be fined due to those lawsuits. On the other side of the spectrum, we have mental cost. Due to those lawsuits, physicians is going to spend a lot of time and energy to deal with this. They might feel very stressful, very anxious, and like in a particular Chinese context, they might be also fearful of violence, both in terms of verbal violence or physical violence from the patient side. And in the middle of the spectrum, you may also think about some non-pecuniary costs, like they might feel fatigue and there might be worse physical symptoms for them, right? And so we are also wondering, to what extent is this non-pecuniary cost important? Well, if we go to the medical literature, it seems to be the case, yeah, like there's, something called medical malpractice stress syndrome, and, there's different explanations about that. And particularly in our paper, we exploit a unique setting in China where those non-pecuniary cost is especially salient. And we use this setting to show the importance of defensive medicine through those mental cost channel. And how do we add to the literature? We relate to the literature documenting the physician's responses to the state-level tort reforms. And those tort reforms are usually regarding the financial liability exposure. And although sometimes those state-level reforms may not be salient to individual hospitals or physicians, so we add to this strand of literature by examining the physician's responses to direct malpractice litigation against themselves or their colleagues. And we also provide strong evidence of defensive medicine due to the medical cost channel. And the fact that they practice more defensively due to mental cost suggests a limited impact of those tort reforms that focus on the financial liability exposure. Because if the physician's responses are primarily due to the mental fear, then any change in terms of how to address the financial liability would not be effective in curbing defensive medicine. On the other hand, we might think the leniency in financial responsibilities for the physicians might trigger the patient to resort to other ways, like including violence, to address those issues, which might trigger further mental frustration to the providers and which might even further induce defensive medicine. And we also talk to a very limited amount of empirical evidence that talk about the physician's responses to direct accusation of medical malpractice. And our value added here is that, first of all, we also focus on a hospital-wide spillover effect. And to the extent that we see those spillover effect, not just for the litigant department, but also for the other department in the same hospital, this shows that there's a more influential role of defensive medicine across different specialties. And it also suggests that if we were to use the physicians or the department that were not subject to malpractice as a control group, we're going to underestimate the treatment effect of such malpractice liability. And furthermore, we also add to this strand of literature by showing the importance of this mental cost channel, and we also believe we provide novel evidence in a developing country setting, while all the work that listed here primarily focus on the US setting. All right, now speaking of setting, let's talk more about the Chinese setting. And we're interested in this setting because it provides an environment where there's very negligible monetary cost regarding malpractice lawsuit for the providers. First of all, physicians are barely financially liable. So hospitals buy malpractice insurance to cover such event. And based on this insurance, the maximum out-of-pocket compensation is $15K US dollars. What is this? What does this mean? So this is equivalent to 1/3 of the US mean compensation. And usually hospitals or the hospital department is going to be listed as the defendant. But in case that if the liability can be traced to a specific physician, then based on our survey for the physicians in the sample area, a maximum of 2/3 of the monthly income will be deducted from the physician's payroll. So this doesn't seem to be too big of a deal. And it's also very unlikely to incur other kind of financial costs, such as losing business or being fired. For those of you who are familiar with the Chinese healthcare system, that the China has a very hospital-centered healthcare system. So each hospital has very stable patient volume and market share, and we also verified this in our own data. And from our own data, we also show that there's a physician who happened to be listed as a defendant for one of the medical malpractice lawsuit. And we traced down this physician through media, through any information we can find online. And we actually found that this physician was promoted to the chief in the following year and was awarded excellent work. So it seems that a malpractice lawsuit would not affect the career path substantially either. However, on the other hand, the providers are suffering from huge mental cost due to the physician-patient conflict in China. And why is that the case? Because given the regulations of how China is handling those medical disputes, the regulations tend to understate the liabilities of the healthcare providers and the compensation to the patient. So patient resort to violent threat as an informal enforcement of the law. And so that's where usually even those malpractice lawsuits are accompanied by violent threat. And this is not an uncommon phenomenon in China. And now let me talk briefly about the data and empirical strategy. And we're going to bridge two sources of data. The first source is the inpatient medical claims data from a healthcare security administration of a single Chinese city. So I'm not allowed to say the name of the city, but I can tell you this is a mid-sized city that is quite representative among the Chinese cities, and features a population of about 1 million and is located in Sichuan province. We have the universal record for hospital inpatient visits from 2014 to 2018 in the 28 hospitals in this area. On the other side, we also bring in the universe of litigation record from this website called China Judgment Online. That's where we get information about the plaintiff, the defendant, and we get more information regarding each timeline during this litigation process, and how patients suffered, what is the adverse outcome, and the decision and the compensation amount in the end. And in total, during these 4 years, we have 64 medical malpractice lawsuits. And we should think about those 64 cases as shock, okay? Because there's a random quasi-random timing of those malpractice lawsuits. That's what we believe. Because in the literature, it has been shown that those litigation is often unexpected, in the sense that negligence rarely leads to litigation, but on the other hand, medically correct care can be subject to lawsuits. Okay? And in our data, we further confirm that, as shown in this figure, if we consider the days between the patient discharge date and the initial expert review date, so the initial expert review date is the day one where the providers know they're going to be involved in the malpractice lawsuit. So you can see that the timing of this malpractice lawsuit is quite unpredictable. Right, there's quite dispersed in terms of the days between the patient outcome and the initial malpractice lawsuit. And there are positive mass across this support. So that's why we're going to treat the timing of malpractice lawsuit as quasi-random, and we're going to put this whole exercise as a difference in difference analysis and treating those 64 malpractice lawsuits as a shock for the exposed hospitals. On the other hand, in terms of the difference in difference, we're going to choose the event timing in a way so that we feel comfortable to say this is a supply side response. So how do we do that? So here we're plotting the timing of a medical malpractice lawsuit. It starts with the patient having this adverse outcome. So there's an inpatient injury occurred. And then when the patient or their family decided to sue the hospital, they're going to initiate a first expert review. So the date of the first expert review serves as a precursor of the malpractice lawsuit. And that's formally the day that the hospital and the physicians know they're going to for sure be sued by those patients. And then this case is going to be initiated, and it later went on for public trials until the case is closed. And it's worthwhile to note that from the date of first expert review to the public trial, during this period, the information about this malpractice lawsuit remained only for within this litigant hospital and the patient, the plaintiffs. So we're going to utilize this timing to choose the first expert review date as the event date and to see how physicians respond afterwards. And we're going to choose a relatively short window to make sure that within the 2 months after those shock, those information about this medical malpractice lawsuit remain within that particular hospital so that, there's no demand side response or it doesn't really contaminate other controlled hospital, which didn't experience any malpractice lawsuit. So eventually, we're going to adopt a stacked difference in difference specification, and we're going to include case-specific hospital and time fixed effect along with a rich set of patient characteristics to account for any confounders. So what do we find? How do physicians respond to each lawsuit? If you look at this graph, I want to first of all draw your attention to the y-axis. Those are different outcome variables that we examined. And now let's focus on the blue triangle. The blue triangle documents the hospital-wide response. Okay, so there's an exposed hospital, right? Because essentially our design is try to compare this within hospital change, and for the exposed hospital versus a non-exposed hospital. So the blue triangle tells us the responses from the exposed hospital. If you look at the surgery, the result tells us that there's a decrease in the likelihood of surgery after malpractice lawsuit. This makes sense because in our data, almost half of the case is related to a failure in surgery, and those cases usually have a higher probability that the hospital is going to lose. So it seems that after malpractice lawsuit, this litigant hospital became more conservative in a way that they reduced the frequency of surgery for their patient. On the other hand, if you look at this Chinese medicine ratio, this is the ratio of the cost of Chinese herbal medicine over the total cost. Why do we consider this measure? Because the Chinese herbal medicine is shown by the literature to be neither effective or harmful. But this is a way of assurance to show the physician's due diligence. And we see that after malpractice lawsuit, there was an increase in terms of the Chinese herbal medicine ratio, consistent with the story of defensive medicine. And similarly, if we examine the lab cost ratio, this is a cost spent for those laboratory tests, we saw a increase as well. Again, a form of assurance behavior to do more tests. On the other hand, we also see those avoidance behavior where the exposed hospital tends to reject more high-risk patients. So the volume of high-risk patient decreased. And they also tend not to accept any referral admission, right? So if other hospital refers some patient to this litigant hospital, now they reject more of those patients. And there's no significant change in terms of how they refer their patient to other hospital. Overall, because we see both the reduction in surgery and the increase in the lab test and Chinese herbal medicine, if you look at the first row in terms of total cost, it seems that these two forces offset each other and we see a relatively null effect in terms of the total cost. But what does this mean in terms of patient outcome, right? So there's this change in those treatment patterns, and is this tried to improve in the patient outcome? So we examined two types of patient outcome. We examined in-hospital mortality and 30-day readmission rate. And because there was no change of this in-hospital mortality in any of the specification, and also the coefficient is too small, we omitted from the figure that we showed during this presentation. However, the result for this in-hospital mortality are there throughout all the tables in our paper. So here in this talk, let's focus on the other health outcome, which is the 30-day readmission rate. So you can see that hospital-wide, there's a slightly worse health outcome, or there's no change in this health outcome. And this further shows that the pattern that we see here is consistent with defensive medicine in the sense that those changes occurred not because of the consideration for patient health, right? And furthermore, now let's look at the red and the green dot, the red dot and the green square. That's where we're going to see that the responses are concentrated in the department that is either, directly sued or it's highly similar to that. By highly similar, you should think if OB department is sued, then the GYN department is highly similar. Or if the neurosurgeon department was sued, and then the cardiologist surgeon department is going to be considered as a similar department. So we see that, first of all, there's a hospital-wide responses, but the effects are stronger for those sued or more similar department. And just based on this figure, we already have the first counter evidence for the scenario 2 about the error correction, right? So earlier we said a direct competing story for this defensive medicine story is that maybe physicians are just correcting their error because now they were sued. But notice that here, we didn't see any improvement in patient outcome, right? So if they are trying to correct their error, maybe, right, or most likely, we're going to see some improvement in the patient outcome. And the second evidence we want to show you to rule out this medical error correction story is this event study figures, right? Of course, this figure serves more purposes for you to see there's no pre-trend for almost all the outcomes that we examined. And this figure also help you to visualize how long-lasting this effect is. Here, the frequency of the event timing is by week. So we're actually seeing the effect to be relatively transitory in the sense that for most of the measures, they fade away within 8 weeks after the incidence of malpractice lawsuits. And this transitory effect actually support this interpretation, or at least rule out this interpretation of error correction. Because if providers are correcting their medical errors, we should see a more sustainable and more consistent effect after such lawsuit. And we further try to rule out the scenario 2, the error correction story, by looking at the heterogeneous response by the winning cases versus losing cases. So winning cases are the cases where the hospital won this lawsuit. That's where we tend to believe that there's less evidence or less potential of the potential mistake. Yet we still see a highly similar responses between the winning cases and the losing cases, which again strengthens the interpretation of defensive medicine rather than that the physicians or hospitals are correcting previous medical errors. And here, the last piece of evidence we want to show to strengthen our interpretation is to look at how or whether providers tailor their responses by the alleged reasons of those malpractice lawsuits. So in the data, roughly speaking, sometimes the patient sue the hospitals because the alleged reasons might be a failure in surgery. So there are surgery-related reasons. And in other cases, the reasons might be a missed diagnosis or insufficient treatment. And we call those other reasons. If the physicians are correcting errors, we should expect that for the cases where the alleged reasons are failure of surgery, we should see probably a much larger response in terms of the reduction of high-risk surgery. While for the cases where the potential mistake could be missed diagnosis, we should be able to see a much larger response by doing more lab tests. However, if you look at the responses here by comparing the red dot and the green square, we're not going to see the pattern that I just described. And in fact, if we look at surgery, right? So the response of the cases where the alleged errors are failure in surgery, actually the effect is non-distinguishable or even slightly smaller compared with the responses to the cases where the alleged error is not due to failure in surgery. This is another piece of evidence that we believe that it's less likely that the providers are trying to correct their corresponding medical errors because we don't see a tailored response corresponding to the reason of this litigation. So far, hopefully that we've convinced you that there's a defensive medicine pattern going on instead of physician correcting medical errors. And now we're going to bring in more evidence to show that we believe this is more likely to be due to the mental cost channel, right? So just as a beginning, when we showed the institutional background, that's where we believe to start with, in this particular Chinese setting, the effect of financial cost is going to be super low either way. So it's primarily going to be the mental cost due to this institutional feature. And here we're going to use the data to provide more evidence. The first piece of evidence is that going back to the responses by winning versus losing cases, we saw a very similar responses between the two cases. And if the financial cost is a primary reason, we should be able to see a much larger responses for the losing cases, right? Because that involves like a higher financial stake. There's a higher financial loss there. Yet we see a very highly similar response, and that strengthens this interpretation of mental cost. And the other evidence is that we're trying to compare the response to those medical malpractice lawsuit to a criminal violence event during our data period. So we've exhausted all the media search and we identified one case where the patient just went to the hospital and caused severe injury for one of the physicians there. So this is a criminal violence case instead of a malpractice lawsuit. And such violent attack is going to bring a much larger mental shock to the physicians. And indeed, we saw a response which is 10 times as large compared with our baseline estimate of the response of medical malpractice lawsuit. So all those evidence lend some support for this mental cost channel. And for the sake of time, I'm going to skip a lot of robustness check, but here are some summary of them. In case that you worry that the rejected high-risk patient go to the other control hospital might contaminate our control hospital, we repeat our exercise by excluding the control hospitals of the same or higher tier, because those are the hospitals which probably the rejected patient would go to, right? Because they are higher risk, because they've chosen this hospital, they would go to either the same tier hospital or the higher tier hospital. But our result remains robust, even though we have a more restricted sample of the control hospital. You might still worry about demand side response. We show that the patient volume didn't change, and we show that the patient composition didn't change either. So there's no severe sorting going on regarding how patients select into different hospitals. And you might still worry about the incidence of such lawsuit might still be correlated with hospital-specific circumstances or trends. And for that, we did a placebo test where we are going to select a group of placebo-treated hospital from the control group where they're the most similar to the treated hospital. if the result that we see are indeed triggered by those hospital-specific trend, we should also be able to see the result for those placebo-treated hospital which share a similar trend or similar operational feature. However, we didn't find any effect for those placebo-treated hospital, which we are trying to say the effect that we documented are highly unlikely to occur without the responses of defensive medicine to the malpractice lawsuit. And for the last several minutes, I want to introduce more interesting result that we find, which is suggestive of this salient story. So first of all, we look at, what would be the case, because some hospital, they have a lot of historical lawsuit. And some hospital, they only experienced one lawsuit in our sample, right? Would this response be different if a hospital has experienced a lot of lawsuit? And for that reason, we're going to look at our responses by hospital tier, because the higher hospital tier, they often experience more malpractice lawsuit. So if you look at here, we didn't actually see that the effect or the responses become smaller as hospital experience multiple lawsuit. Okay, this might point to a story of salience where every time, because malpractice lawsuit is still relatively infrequent, so every time when it happens, it draws the hospital's attention and it's emotionally charged, and so every time we're going to see a response. And another piece of evidence is that we look at the response, like how hospitals respond to patient death, right? This is also some adverse event. And we overall see that the hospitals respond to death in a similar way as they respond to a lawsuit. They practice more conservatively. However, such pattern depend on whether there's a lawsuit happening right before the patient death. If there's a lawsuit happening right before the patient death, this current patient death without triggering further lawsuit is actually going to bring good news to the hospital so that they actually respond more aggressively. So this is to say the hospital's response to patient death depend on the timing of the previous lawsuit. And this tells us if there's a recent lawsuit before, that's a salient event, right? To the extent that if the hospital experienced a recent patient death without lawsuit, they would still think about that malpractice lawsuit and treat the current patient death as a good news because it didn't invite further lawsuit. And so that's probably why they tend to respond in a different direction in these cases. So for the sake of time, let me conclude here. So in this paper, we utilize the unique Chinese setting to provide you new evidence of defensive medicine. And particularly, we show strong evidence of the defensive medicine through the mental cost channel. And this implies that the tort reforms that try to target financial liability may not be sufficient or effective. And we further show there's spillover effect, and this suggests a more influential role of malpractice litigation across different specialties. And lastly, we show that physicians respond to every lawsuit, regardless of how many had already happened in the history. And this suggests something about how should we think about the timing of the monitoring regarding like the physician's behavior. All right, so I'm going to stop here and thank you very much. And we appreciate any questions or comments you might have. Thank you.
Thanks a lot, Jia. And thanks actually to both of our speakers for the wonderful presentations. So I think we see two very insightful work that shows us how important the psychological or mental factors are to the physicians. So I think in the chat we now have some questions. The first question directs to the first presentation, and I think it asks more about some like background information about the policy change. So the question is asking that when the pilot project starts from like the fee-for-service to the prospective payment scheme, is there any opposition or resistance from the providers? And from the perspective social power, it seems plausible that the providers might actively lobby high-ranking officials to highlight the limitations of introducing such a payment scheme. So do you have any thoughts on that, Wei?
Yeah, I think it's a very interesting question. Actually, I don't know whether providers actively lobbied against the reform, but according to our data, the UE BMI actually set a fixed payment slightly higher than the pre-reform average medical expense per admission. For stroke readmission, the fixed payment is 18,000, and the pre-reform average medical expense for stroke rehabilitation in our sample is over 14,000. This practice is actually similar to the PBS reform for post-acute care in the US from 1998 to 2003, which also increased the average payment to post-acute care facilities. And this higher payment level may help mitigate the reduced marginal financial incentives in the PPS and may which may discourage providers from admitting high severity patients. Yeah, that's so that I think this collective opposition or resistance is less likely to happen in our context.
Yeah. Yeah.
Yeah, thank you.
Okay, thanks, Wei. Yeah, we have some other questions for our second speaker. And I think probably the first part of the question is like beyond the research itself, and it's also more about like the general story or what is like happening in China. So here's a question that asks, is there like a workforce shortage phenomenon where young doctors might avoid applying to departments that perform procedures with a relatively high risk of being sued? And like yeah, our audience is like curious if these factors have led to a decline in recruitment for some specific specialties, right? Jia, probably want to first say something about this.
Yeah, thank you. So I think this is definitely something that we have in mind and wanted to explore. But I have to say we haven't had an answer yet for this question. I think yes, it's very likely that this is going to show up in the longer term. So it's definitely beyond the scope of this paper, but I think it's a very relevant question. And my prior view, if I were try to say something without any support, I would say, yeah, like probably there's something going on in terms of the labor force supply for those specific specialties, especially given the case that there's this violent threat to certain special like doctors in certain specialties. And
Yeah.
there's also a second question that
Right. The second question asks about whether basically some heterogeneity across like hospitals. Probably there's some variations in the size and the capability that the hospitals might handle such occasions. And so the audience is curious about whether such institutional factors are controlled in the study and like how you think about this issue.
So if those size or capability of the hospital's internal organizations, if those are time invariant, then yes, because we have a hospital fixed effect that could potentially account for anything that is time invariant. So if you are thinking about something along that line, yes, we are essentially considering like within hospital change over time for the exposed versus non-exposed hospitals. I'm not sure whether that was exactly your question, but I would be happy to follow up if it's not clear.
So I think I do have some questions after the talk, probably for both of you. Things we are talking about those like behavioral factors, and I think we are both looking at relatively like a short time response, right? I think for Wei's talk, we have like a data coverage period for about 2 years, and for Jazz work, I think we are restricting to a short period of time to avoid like contamination of like potential spillovers or like the demand set response, right? So like for those like behavioral factors we've already seen from your talk that these are very important, but like um, probably the effect could be short lasting. I think this like effect have already some suggestive evidence from Jia's work, right? So I think probably to be more specific for Wei, since we are talking about some like policy suggestions, right? So even though you are not having empirical evidence for now, but like how would you expect your policy suggestions will be different if we have some speculations about like the long-term response of those kind of the reference dependence kind of preference we'll have, right? And then probably for more specifically for Jia's question, for Jia's talk, I think there are some work. One piece of the work is done by the first paper's co-author, Professor Yi Junjian. I think their work also look at the response to malpractice lawsuits. And I think in their work, they actually found that some long-term response even after probably the second year after the malpractice lawsuits. And then like, how do you think it's different from your citing to probably some other sightings that make the effects probably relatively short-lived? Right. So probably yeah, either of you wanna start first talking about this.
Okay, maybe I can start first. For the long-term effect, I think it is a very important question to consider. Actually, I think the reference-dependent preferences is inherent preferences individuals have, and as I discussed in the future extensions, the reference point may evolve over time, so the long-term effect may deviate from the short-term effect, and because their reference point may adjust dynamically based on their experiences. And the optimal payment path may also differ from the static benchmark we derive. So we think our framework also still remains useful for the optimal design, for the optimal payment design, but we need to accommodate such dynamic involvement in the reference point, and we may have we may derive different payment levels if we consider the long-term effect, long-term dynamics.
Great, and thanks, Shannon, for this question. So I think regarding our work, this is also a valuable question given that we've already documented this is relatively short-lasting effect. And in terms of policy relevance, I think it's still very policy, relevant in the sense that although this is short-lived, but it's repetitively happening, right? So like during this 4 years, there's 64 cases, and that means, like each year there's a certain period, and that there's this higher level of defensive medicine. And that's one. But I think the timing also suggests there's a probably a corresponding timing for the policy intervention. Because like our result would suggest that there should be a lot more monitoring right after this first expert review, even before this case went for the public. So I think that's another relevance in terms of the timeline. And further, because the short-lasting effect also suggests this might be some mental cost going on that tend to be wear off over time. And I think that also speaks to the policy tools might be also tilt towards, physicians' mental health and how to help them to be more transparent about the real malpractice risk instead of their fear or their perceived risk. So I think there are different like dimensions of that. And you also mentioned that there might be there's other work, and I apologize. I think I encountered that work, like a long time ago, but I didn't recall the detail about like the time horizon there. And so I couldn't comment on more in terms of, like the how probably certain specification might lead to this difference. But we did think about why our results are relatively short-lived compared with the US, and some of the literature also documented a longer period of responses. And we think like probably one of the reasons compared with US is like because the Chinese physicians are consistently seeing more cases and dealing with new patients every day. And if our salient story is true, it also like their memory also tend to be crowded out like by newly event, right? So because like maybe the next day or next week there's another patient death and they were not being sued, and that's a good news for them, and so they just move on, and then they just like do this like repetition again and again. And I think that's one rationale in terms of why in the Chinese setting it tend to be more short-lived. But I think like within the Chinese setting it could be due to like even like more localized reason or like the difference in specification. But I think that's a question that we can think more about offline.
Yeah, cool. Thank you.
Thanks.
You both for the great presentation and also like some discussions that we have just now. I think we are at time. I do have a lot of questions that I still want to discuss with both of our speakers, but we can have more discussions later. So I want to thank you both again, our speakers, for the wonderful presentation, and also thank our audience for joining us this evening or this morning, depending on where you are. And we look forward to seeing you again at future events in our webinar series. And I think that concludes our event. Thank you all again, and hope everyone have a great day.